it takes about 8 to 10 weeks of treatment once they're outside of a moldy environment to even start feeling better with treatment. Without treatment, those toxins are going to remain in the body. There's people who've been out of the moldy apartment, house, whatever it was, for 5 years, and they still feel it.
Could mold be causing your chronic health issues? It's possible. It's possible that neurological symptoms like insomnia, fatigue, brain fog could be from mold. It's also possible that chronic gastrointestinal issues, bloating, loose bowels, diarrhea, or even immune issues like food reactivity, skin problems, or joint pain, or paresthesias and muscle twitching. Any of these symptoms potentially could be caused by mold, but that's the problem. How do we actually know if mold is an issue? What I can tell you is that some of the thought leaders in mold, we have tested their hypotheses at the clinic and they have failed. So we're always looking for who has the best handle on if mold is a problem. And I think we found that person. Dr. Andrew Campbell is a medical doctor, an immunologist, and a toxicologist. He's published over 100 papers in this area of mold and mycotoxicity. He sits on a number of medical journal boards, and he has a unique perspective on this. One of the very distinguishing opinions that he has is that urinary mycotoxins or urinary mold tests are not accurate. And that's affirming of my experience. But what he has found is accurate is a blood test for mycotoxin antibodies. And he makes a good case for this. Also, that treatment must include what's known as itraconazole, a prescription antifungal. So between the questionnaire he's developed, and I'm a big fan of questionnaires that gives us an initial screening, plus the testing, and then this nuanced treatment, I think there's hope for, one, identifying who actually has mold, and then two, having a clear path to treatment regarding mold. The final point before we go to the interview, and I deeply appreciate this about Andrew's perspective, is the treatment course takes 6 months, and someone will notice improvements usually within the first couple months. Now, if we juxtapose that to some of the bigger camps of mold care, Shoemake and Neil Nathan, they remark, paraphrasing here, that it may take 6 months before you notice any initial improvement. And I think that is very wrong. There is nothing I've seen in the human body that takes 6 months until you can tell if someone's improving. So for all these reasons, I think the conversation I'm bringing to you today with Dr. Andrew Campbell, at least at current, in my opinion, seems to be the best perspective on mold I've come across yet. It's clear to me that there is something here based upon my own experience and what we've seen in the clinic. But again, I think what's failed is the camp of thinking that urinary mycotoxin testing and binder therapy is the appropriate approach. I always remain fluid in my opinions on these things, but just reporting to you after a few years of working with that camp of hypothesis, I don't think it's that helpful. And there must be something better. And again, I think we've found that something better with Dr. Andrew Campbell. So I hope you will enjoy this conversation as much as I did. Andrew, welcome to the show. I'm looking forward to exploring the moldy, misty, damp world of mycotoxins with you.
Great. Thank you. It's great to be here with you. I've watched what you do, and it's amazing how you can reach out all over to so many people. I congratulate you.
Well, I think together we make an effective team because you're doing, I think, some very, very interesting work in mold. And so with the stage that we've built to amplify voices like yours, I think, again, that really helps the people out there who might be struggling and not sure why they have non-responsive brain fog or insomnia or anxiety or loose bowels or insert any number of symptoms that might correlate to mold. And I think we need to give people better answers. And you have some unique and I think distinguished hypotheses on this. So I really want to explore some of those nuances. But before we go into maybe a little bit more of the advanced in terms of, well, you're not really an advocate of urinary mycotoxin testing, you prefer antibody testing. For the people who are newer to this conversation, let's give maybe a quick recap on what mold is, because not all mold is perhaps bad. You may see a little bit of mold growing on a tree outside, as compared to something that's like I had visible growth all throughout your HVAC unit at home. So maybe just to give people a quick recap on mold, what it is, why it can be a problem. Let's start there.
All right. There's probably about 1 million species of molds out there. Many of them on trees. They affect animals, insects, seafood. They're everywhere. But there's only a few, couple dozen, that affect human beings. And like you said, they're on trees and bushes and shrubs, um, but those don't affect us. Neither do their spores. What affects us is when we have it growing indoors, because indoors is how many square feet? Well, it's pretty finite. It could be 1,500, 2,000, 3,000, whatever. How many square feet is outdoors? Oh, that's a whole other question. So it's very diluted. So inside, it's where it counts. And molds are like plants. Plants produce seeds, molds produce spores. So, and to give you an idea, your hair, my hair, human hair is 100 microns thick. Mold spores are 2 to 4 microns thick. So when you're walking around a moldy room, you're breathing in those spores, and you're breathing, and they reach the deepest part of your lungs, go right through into the alveoli, and transfer directly into the blood. And what do they carry with them? They carry a mycotoxin, and sometimes several mycotoxins. In other words, one mold can make several mycotoxins. It's not one to one. And so when you breathe these toxins in the beginning, if it's just a short time, your immune system takes care of it. But when it's for a lengthier time, then you're becoming toxic. And just to let you know, we said how small a spore was compared to 100 microns for human hair. Mycotoxins are 0.1 microns, the same size as a COVID virus. And the
Okay.
first place they attack is the brain. And that's why people get fatigue, sleep disturbance, anxiety, depression, brain fog, et cetera,
Yep.
et cetera.
Yeah, and I can vouch for the insomnia. Some of the backstory on my side is when I first moved to Austin, Texas, from the lovely, dry, arid, non-moldy California to, I think, Florida and Texas are probably the two most endemic states regarding mold, given the heat and the humidity. There was mold in the HVAC where I lived, and my sleep was horrid. I mean, an hour at a time, then I'd wake up and it would be a struggle to get back to sleep. Maybe I would pop half a tablet of Unisom and a histamine, and then that would get me an hour or two. Then I'd wake up again. I mean, it's maddening. So certainly your comments about the brain are very relevant. And this gets me thinking about what are some key indicators that might be suggestive of mold. One of the challenges I know with this question is like MCAS, like some of the Lyme bacteria, even like small intestinal bacterial overgrowth or fungal overgrowth, the symptoms can be very broad in terms of how it presents and shows up. There's a few things that I've taken from some of your notes about if people have failed with numerous other doctors, that's one potential cue. A heavy involvement neurologically, sort of, building on what you just said. Fatigue and maybe a high degree of allergy or atopy or reactivity, histamine intolerance, MCAS. But are there any other points or key indicators that you would want people to take stock of that might help them? Putting yourself in their shoes. People are going on Google and searching, and it can be so confusing for a layperson. So what else would you provide them if there's anything to help them cue in?
Over the last 35 years I've been doing this, no one has come to me with you're the first doctor I'm seeing for this problem. They've all seen anywhere from 5 to 10 to 20 doctors before, and they have a bunch of tests, then they have a bunch of treatments, and they don't work. So, and I still get about 15 emails a day, 365 days a year from people who've done this and that method of treatment for 2, 3, 4 years, and I'm still sick. Can you help me, doc? So I would say it's because it is confusing. That's number one. Number two, the symptoms and signs can point to a lot of different conditions, which is why I developed 30 years ago a questionnaire that hones it down, and it's free to the public.
And sorry, one quick follow-up on that. Has some of these questionnaires, we use one in the clinic called the FRDQ7. It was validated. I think the name is Sandelman validated this to be predictive of response to antifungal treatment for intestinal fungal overgrowth. Has there been any sort of validation to this questionnaire? Not that I think it's totally necessary, but just out of curiosity.
This was developed with several other doctors. And just to preface this, I base everything I do on medical and scientific evidence, not on what somebody may say on some website, because that's more anecdotes or opinions. In medical school, I was taught, in God we trust, everyone else has to show data. If you say such and such works, wonderful, I'm so happy it works. Can you show me the data, please? And if they can't show the data, well, I'm sorry, it's your opinion. And everybody's got an opinion. We can see it now with all the politics. But anyway, I think that it was mainly developed to help us define things. For example, does it make a difference if, say, a person like you today had a natural childbirth or cesarean section? It makes a difference. Why? Because a natural childbirth, the first bacteria in the baby's in the newborn's mouth is mother's bacteria. In the cesarean section, the first bacteria is from operating room personnel and instruments. So that changes your microbiome, and 70 to 80% of your immune system's in your microbiome, part of your microbiome. So this questionnaire goes through all kinds of details to hone down that it's not that this and it's not this other. The other thing I see a lot of in these people who come to see me and bring me all their tests, et cetera, is that a lot of doctors tend to repeat tests and keep treating. And one good example is Lyme. They keep treating and treating and treating for years with this antibiotics, destroying the microbiome, et cetera. And they never think, could this be something else? Okay. So having said that, I think that I see a lot of healthcare professionals treating test results and not asking the patient things and not sitting down. New patient with me is easily an hour to 2 hours because they've been to so many practitioners and everything else.
Well, I mean, you're preaching to the choir here in terms of prioritizing the patient experience, their response to therapies, their history, their symptoms, and all the clues therein over labs. And I'll also just second your observation. Sometimes we get people who literally have 20 labs, and they think if we just have Dr. Ruscio or someone from our clinic review those labs in more detail, that's going to give the answer. And sure, maybe there's a time in a case where something's been missed, but that's quite rare. And to your point, another one of your points, which I fully agree with, you don't want to do more of the same and expect a different result. And I'll see this with SIBO treatment, like you're saying with Lyme treatment. And we've been doing more, especially over the past 6 months to a year with Lyme. But we always have this standard that we try to adhere to, which is if we're doing the right thing, you're going to know. And sure, maybe we have to modify the treatment approach. Maybe the first approach didn't sit well, negative. So we loosely say, give us 2 or 3 swings at bat, so to speak. And if we don't connect, if you don't start feeling better, and I don't mean, maybe I feel better. I'm not really like that means when you factor out the placebo effect, that means you're no better. It needs to be a yes, I'm not maybe perfect, but I'm clearly sleeping better. I have less paresthesias. I have, well-formed bowels. And I think that's so, so important because the other component of that, which I know you agree on based upon reviewing some of your research, is these patients can then go further and further down the wrong road of treatment and start to forge this mentality of I'm a chronic case, I'm a complex case, and really start to have this sort of disempowering view of themselves when really it's just they needed to make a pivot to the right therapeutic approach. And once they do, they start improving. So fully agree on all points.
And one thing we must remember that's important for everyone is that there's 4 pathogens: bacteria, viruses, fungi, and parasites. And those are all living organisms. They have cell membranes, etc. Toxins, whether it's mycotoxins, mercury, glyphosate, or anything, are a molecule. They're not alive. So the immune reaction is different. Having said that, it matters which lab you pick too, whether it's Lyme or whatever, or SIBO. There is a very popular GI test that a study showed is only 26% accurate. The other side of that coin is that it's 74% inaccurate.
I mean, with a SIBO breath test, that's essentially one of the perspectives we offer to patients, which if you look at the meta-analyses, and this is just a rough number because some clinical trials are using the glucose test, some are using lactulose, but sort of as a pooled average, maybe 30% of people with the symptoms of IBS have a positive SIBO test, which is helpful for maybe that 30%. But then what about the other 70, the majority of people who have those symptoms but don't actually have the lab positive? So, again, I'm fully with you in terms of we should be very, very parsimonious with the use of lab work because it's such an easy way to waste money and really divert focus to treating a lab and not listening to the patient right in front of you. And I do want to come back to a more detailed examination of your thoughts on the labs, but I wanted to spend a moment or two on the environment. I'm curious, do you agree with my perspective on this, which has been if someone is in or partially in a moldy environment, like let's say their work rather than their home, but there's some mold that they're being exposed to environmentally. My position has been people will have some inkling. Like I feel good when I'm away from home and then I come home and I seem to regress. Or I took a vacation and I felt better. I went back to work. I started noticing the brain fog and the loose bowels again. I think there needs to be some sort of at least a clue or a cue of environmental reactivity. Not everyone agrees with this. I'm curious, what's your perspective?
Yes, I mean, obviously, everyone's immune system is unique and different. And one of the key things is I went away for a vacation for 2 weeks and I felt great. I came back home, I felt awful. I started feeling bad again. Or I stayed at home because Milton came by and I felt better. Then after they rebuilt everything, I went back to the office and I felt horrible. So, those point you in the direction of where it's coming from. It could come from the gym you go to, not your home or your workplace. So I've seen that happen. I've seen it happen because it was in the car. And
And sorry, one follow up there. So do you notice that when you probe into this with someone, is there a suspicion like, oh, I feel good, then I go to the gym, I feel kind of crappy, or I think I've noticed if I spend too long in my car, I have an exacerbation of the brain fog. How often is there, upon questioning, some sort of environmental correlation the person can draw?
I wish there was. Think of it this way. A couple catches the flu. One of them is well in 2 days. The other one's sick in bed for a week. Same flu. same couple, they caught it at the same time. So some people feel it in one way and other feel it a different way, depending on that person's immune system. So that's one differential. The other that helps me differentiate this is the questionnaire, because it literally says, where do you feel bad and where do you feel good? Where do you feel better? Et cetera, et cetera. So, and by the way, I'm not pushing my questionnaire. It just, for me,
No, I think questionnaires are
it's right
great.
in there. So it
Yeah,
makes
I
it
think
easy.
having a way because one of the things that I've noticed is patients don't always do awesome on the spot. When you say, "Tell me all about this, go," and they may not have the best, especially if they're battling with something like brain fog. They need a moment to sit with a form, think about it, have their memory be jogged, and be able to really pay attention to that form. So yeah, I'm fully with you. I think questionnaires are a really unsung hero of the healthcare approach.
Yeah, and plus they're huge time savers, because to ask all those questions would take me easy an hour, whereas they bring it filled out and hand it to me, and I can look through it in 5, 10 minutes and see, wow, okay, this is good, this is that, this is the other.
Oh, and does that form quantify? Do you and this is something I really like about a few of the forms that we're using, is it's going to give you a score, and there's sort of an interpretation criteria
Yeah,
of mild, moderate, severe risk.
no, it doesn't do that because there's too many variations. Because there's a difference if it's a teen, if it's a child, it's young 20s, late 60s, mid 40s. Um, the 50s is 40 pounds overweight and takes blood pressure medication. The 22-year-old is fine, but has some irregularity in the bowels. So all those
Right.
things.
So it kind of helps you hone your intuition rather than
Well,
give you a quantifiable
what
score.
I've always done is publish findings. So I have over 100 studies. I've got chapters in textbooks, but I've published over 100 studies in medical journals, and I speak every year at several medical conferences. We'll be at A4M in December, at the International College of
Oh,
Integrative
I might see you there
Medicine.
then.
Wonderful.
Oh, okay. So fully with you on the environment. It sounds like sometimes you'll have a read, and then sometimes it won't be clear, and maybe this is due to a latency or a prolongation of the immune response. So then you'll look at the questionnaire and potentially testing, which we're going to come to. But there's a few other environmental questions I wanted to speak to. Is there a period of time when someone's out of the moldy environment that they'll notice improvements? And I ask this in part because in some cases we have them do what we call the Airbnb test. We'll just have them rent an Airbnb for maybe a week and get out of their current environment. It's not perfect because some people, if they're, let's say, colonized, which is one theory, the mold is being brought with them or maybe on some of their clothing. But, is there a interval, as like a range? Maybe the fast responders, they're better in 2 hours and the slow responders need a week, or do you have any indications on this?
Yes. Since these are toxins and not something living, it takes about 8 to 10 weeks of treatment once they're outside of a moldy environment to even start feeling better with treatment. Without treatment, those toxins are going to remain in the body. There's people who've been out of the moldy apartment, house, whatever it was, for 5 years, and they still feel bad. And they still have a series of symptoms. And they can't function very well, and they have all kinds of issues, brain, gut, et cetera, et cetera. So there's, again,
Now,
everybody's.
is this in a group that you're expecting are colonized? I'm assuming this is more of like the worst case scenario of people who are colonized.
No, and I've treated mom, dad, and 5 kids, all live in the same home, all the kids under the age of 15, and one had this, and the other had something else, and the mom had that, and the husband had the other, and you know, it varies. But what helps me in all of that to determine I want to know the quantity of each mycotoxin in the body. That helps me say, oh, wow. And which mycotoxin do you have in your body? For example, one is called zearalenone. It's a highly estrogenic mycotoxin. So if you're a young male and your testosterone is low and you go get testosterone cream or shots or whatever, it's not going to go up. What about if you're female? If you're in menstruating female, say age 14 to 45, you're going to have all kinds of abnormalities. You're going to go to the GYN. He's going to try this and that and the other, and it's not going to help. Well, zearalenone also causes early telarch, which means you develop into a woman before age 8. So you start menstruating before age 8, things like that.
So,
So
and
depending on,
this
and I
question might
just
be a
gave
little
you
bit.
1 out of 14.
Sure, sure. And on the hormone piece, and admittedly, this is probably a little bit in the weeds, but is this something that you're going to see low testosterone on testing because it's impacting hypothalamic pituitary feedback loop and therefore production of testosterone? Or are you seeing this more so affecting the receptors where there might be a somewhat normal level of testosterone, total and free, but they just exhibit symptoms of low testosterone?
There's 3 of these mycotoxins that have the ability to lower the testosterone by binding to it and then making the brain think it's made plenty, and I don't need to send signals to make some more. So many of these men are almost at sterile levels with testosterone. And of course, what comes with low testosterone? It's not only the fatigue, the kind of uninterested type of feeling, but it's also your muscle mass and a number of things that are affected, including heart.
Yeah, but some of those studies are interesting, I think, on testosterone replacement therapy having cardioprotective effects, as long as the dose isn't, like the excessive bodybuilder sort of dose. Okay, ERMI. ERMI is a test for our audience. It's essentially like a Swiffer that you swiff and dust your house with. I haven't been a fan of this, nor the auger or gravity plates. I know you're not either. Any thoughts you want to offer people? Because I'm sure, especially with our audience, they're so educated and proactive. Some people definitely who are watching or listening to this have done ERMIs and they've concluded they have mold based upon the ERMI, or they're thinking about doing an ERMI, or maybe a gravity plate. So what would you want to advise people on who are thinking about either one of these tests?
There's a lot of confusion about these different tests and which is good and which is bad. And every one of them has pros and cons. So I'm a medical doctor. I don't know about buildings. I know about the building we live in, which is our bodies, but not the rest. So had did 2 videos with a fellow by the name of Brantley May, who's a building engineer, and I asked him, which is the best test? He says none of them could be called the best. Each one has good and bad. And he went through each type of testing, the plate, the EMA, the ERMI, the air traps, the everything in this video. So, and it's on YouTube. So rather than me opining about something that's not my area of expertise, I'm going to let somebody with a degree in it and let him tell you. He does say the ERMI is not a great test, that there are better ones. But rather than me either say yay or nay, watch somebody who knows what they're talking about, and I don't.
Yeah, I mean that's fair. Yeah, I think that's a mark of an educated mind. One who is willing to say they don't know. So commend you for that. And I'll make a note of Brantley May. I have him in the notes here. He might be a good person to refer some of our patients to, because this can be really tricky for people. One of the things that I want to offer, which is the combination of my clinical experience but also my personal experience, is when I was in that moldy environment, the mold inspector, shockingly, didn't look at the HVAC, didn't look at the heating, ventilation, and air conditioning unit. And I don't know if this is the issue in all states or just in Texas, but what I learned after the fact was these mold inspectors, if they're not licensed HVAC technicians, and most of them are not, they legally can't open up and look into the HVAC. So something for everyone to be aware of. Again, this may not be an issue in all states. Maybe it's only a legality in Texas, but it was shocking to me that this guy wanted to do $5,000 of remediation based upon one baseboard in the garage that had mold. Yet he didn't find the visible with the naked eye all throughout my HVAC. And I learned a tremendous amount from that experience. And this is where you need to just, as a patient, as an individual watching this, think through these things logically. Don't let the fear of the consultant said there's mold in the baseboard, and all of a sudden you go on this sort of fearful cascade where it shuts down logic. I took a moment and I said, it doesn't make sense that every time, I had noticed anyway, the air conditioning turns on, I feel different. I feel foggy. So the baseboard thing doesn't really fit. And so I asked a follow-up question to this consultant. What about the air conditioning? And that's when he informed me, I can't look at that because I'm not a licensed HVAC tech. So after I picked my jaw up from the floor, I then found an HVAC consultant, and within 30 minutes, he said, holy smokes, on his cell phone, he said, look at all these, visible signs of mold, because my unit was actually overpowered for the square footage. So what it did was it cooled so fast that it led to condensation on the one hand, and it also didn't have enough time to run to dehumidify. So it was kind of like a double whammy. So, just for the people out there, make sure you don't overlook the lungs of your house. And I'm not sure that most of the mold environmental consultants will actually do that.
Yes, I agree with you wholeheartedly.
Yeah, I learned that one the hard way. Let's talk about colonization, because this is something that's also controversial. Or I guess it depends on who you ask, right? But there's differing opinions out there on this. I can say that when I left the moldy environment, I very quickly felt better. And there seems to be at least a group of people who, when they get out of the environment, and if maybe we use a probiotic, some basic supports, without doing any sort of overt mold killing, they just within a few months they're right back to normal and they're all fine and good. Then it seems that there might be people who colonize, and the way I've been thinking about this is, if someone is colonized, or at least the question I'm asking myself, are they going to be much more likely to exhibit either nasal or respiratory symptoms? I don't know, but I'm curious, is that a clue that you look for? Meaning, do colonized people exhibit? Because I know that people will have colonization mainly in the nasal and the respiratory tract. So it would make some sense that they have some sort of nasal or respiratory symptom if they're colonized, but maybe it's not quite that simple.
Dr. Konikow, chairman of the Department of Ear, Nose, and Throat Surgery at Mayo Clinic, published a study on 210 patients with chronic sinusitis. He took them to the OR, cleaned out their sinuses, and sent the stuff to the laboratory, asked them to report back what is the most common organism they found. 96% was mold. He actually petitioned that the term chronic sinusitis be changed to chronic fungal sinusitis. Anyway, he treated it.
That's an amazing data point.
He treated it with two things, and people got better rather quickly. He treated it with one, oral itraconazole, and number two, amphotericin B nasal spray. Now, having said that, mycotoxins, again, which are they're a molecule, go through the cribriform plate, which is the plate we have in the back of our right here, and into the brain, and it affects the pituitary hypothalamic pathways. What does that mean? What does the patient feel when they have that? Fatigue, brain fog,
Dysautonomia, perhaps.
so all the things we've talked about. Okay.
Yep.
It doesn't add to it. That's what it is. How much fatigue can you get? Well, some people get so fatigued they don't want to get off the couch. Others barely make it through the day, et cetera, et cetera. We're all different. But the point is, it all goes back to the brain. So as far as colonization, what is important for me as a clinician is, where is it colonization or not colonization? Is it somewhere where you are now, or is this something you picked up years ago and got caught? Because that makes a difference in your evaluation of each person, each patient. So what's important is it recent, or is it way back when? Is it current or not? And those are the things that help people in healthcare determine, how am I going to help this person?
Hmm. This, again, listening to the person makes a whole lot of sense, right? So you're saying look at the history, onset, and then also you can further either build or detract from the case if there's nasal and respiratory symptoms. But it sounds like you're not looking at those as an exclusive
You,
indicator.
you
Okay.
got it.
Again, so many things. Just listen to the person, ask the right questions. And the way I think about this or visualize this is almost this ledger in my mind, for and against. And every hypothesis I have, I ask a number of questions, and it's, 1.4, 2 points against, 3 points for, and then that gives you a probability. And I think it's important, and I think we're on the same page here probably, but for patients to understand that a good doctor is going to think in probabilities. And I just offer that because sometimes I'll see, especially in today's age, the most confident person tends to do really well with, short snips on Instagram. And I know those things are attractive and the confidence is probably inspiring because it sounds like, oh, this person's really got it figured out. But the longer I spend in clinic, the more I realize, you have maybe 3 or 4 hypotheses on what's going on with a person, and you have a probability score for each one of those. So to say something like so steadfast and so confidently, I think is probably more reflective of someone who's not really paying as much attention as they probably should.
Obviously, I've treated over 17,000 patients with molds and mycotoxins, so I've seen it all. I've treated children 2 years up, and my oldest patient was 92. So you see a huge variety, but that's where you've got to use your knowledge and your ability of discerning things to be able to realize what helps one person versus not, or another person.
Let's go to testing now. So I know you're not a fan of urinary mycotoxin tests, and you prefer the blood or serum antibodies for the mycotoxins. I just want to share my experience. At the clinic, we spent about a year and a half where we fairly diligently tracked people who had a suspicion of mold exposure. We did a baseline urinary mycotoxin test. We tracked them over time, doing numerous therapeutics centered around binders. This is kind of like the Neil Nathan camp protocol we were using at this time. And then we'd retest every 3 months or so. And boy, we could not draw any correlation to the level of mycotoxins in the urine and the level of symptoms. Nor, not at baseline, not midway, not endpoint. And we certainly weren't seeing that people at the end of their course of treatment consistently had lower levels of mycotoxins in the urine and correspondingly improved symptoms. And we're planning on publishing this. And actually, one of our colleagues, Tani Dempsey, who's a Lyme specialist, she has similar data sort of from her, in office observations. So we're going to try to pool this and publish something to share with people because we really were curious and in earnest. We tracked this data very meticulously. And again, at the end of a year and a half, I concluded these urinary mycotoxin tests, I can't confidently recommend them or pull any valuable data from them. So I'm sure I'm probably preaching to the choir, but that's just my experience with the urinary mycotoxin tests to date.
So there's 3 points. As a doctor, I want to know what's in the body. I don't want to measure what's left of the body. And you can have certain foods, for example, milk. 91% pasteurized milk contains 1 to 4 mycotoxins. Where is that yet it's in parts per billion, which is called the TDI, tolerable daily intake, set by all kinds of government agencies. Here, the European Food Safety Authority and all kinds of things. So those parts per billion, where are they going to go? Well, you're going to excrete them through urine. And that's what is being measured. When you measure in serum, you're measuring how much of each mycotoxin is there, not this group of mycotoxins or not the metabolite. One test, urine test, measures the metabolite. Well, for instance, if you and I today go somewhere and have dinner and we eat some asparagus with our dinner, the rest of that evening, our urine is going to have the odor of asparagus. That's the metabolite. The other one is measuring a group of different mycotoxins in parts per billion, which is precisely what is excreted from foods and urine. And that's been shown in many, many studies. And remember, in God we trust, everyone else has to show data.
And so you're not just trying to head off the past, the people who might be in a place where they're a little bit anxious about their diet. You're not saying that this tolerable amount of mold in foods is a problem. You're saying it's normal, almost like going for a walk in the woods and there's that tree with the mold on it and you breathe in a little bit and it's not a problem. Is that correct?
What I'm saying is it's correct that many foods have parts per billion. What is a part per billion? I asked a scientist because I'm a visual, I need to see it. He says, take 1,000 football fields, cover them with golf balls, and remove one golf ball. That's part per billion. That I can see. So it's been shown in scientific studies, medical studies published that these work. And in many of the studies I've published with other doctors, etc., we've shown how effective it is. And a study came out in the journal Toxins in October 2022, 2 years ago, precisely now 2 years ago, that compared urine and compared serum testing. And they said in order to get a really accurate anything on urine testing, you'd have to do it several times during the day over a number of days because it depends on the creatinine level. And creatinine is affected by how much exercise you do or not do, whether you're male or female, what is your age, and also how much did you have to drink that day? How hydrated are you? Whereas they said that the serum testing was the most accurate, precise, and sensitive test compared to the urine testing.
And the urine testing, they're not indexing to creatinine. It's actually a great question. I know so many tests will index to creatinine, but the urinary mycotoxin tests aren't. They're not adjusting for that.
No, as a matter of fact, I was informed earlier at the end of last month that a nonprofit group did testing. They did split samples to all the labs that do urine and the ones that does serum. And the urine sample, there was anywhere from 20 to 70% variation between the split samples, whereas the one on serum was a carbon copy. The other thing is, again, and I don't mean to harp on this, but I want to see studies. If you say binders are great, wonderful, show me a study, please.
Yeah.
One.
Well,
One
there
study.
is a small, I think, devil's advocate argument to make there, which is there are some areas where there's just a paucity of data, and if there's a reasonable mechanism, if it's safe, not very expensive, then I'm open-minded. So I try to be evidence guided, but not evidence limited, which is, whenever we have the data following the data, then there are some cases where the best we have is maybe a mechanistic study, or maybe there's one small pilot study. I'm still open to those therapeutics. I'm just much more cautious.
I'm always open. I only need to see the data. And if you
But what do you
can't,
do when there's not
otherwise it's
sufficient data?
basically anecdotes. My patient got better by taking this. Wonderful. One patient did well. And I did another one, and a whole bunch of them got well. Okay, let's sit down and maybe design and publish your findings. And I'm the editor-in-chief of 5 medical journals. I'll be happy to help you.
I'm with you there, and I'm going to actually take you up on that maybe when we go to publish our mold data. So that would be great. So the antibodies more consistently are going to track with. Well, I guess that's the question. Has there been any data that has looked at correlation between serum mycotoxin antibodies and level of symptoms?
The more antibodies and the more of each mycotoxin, the worse you are. The worse you
Now, has
feel.
this been formally published, or is this something that is in the clinical observation stage?
Again, if I can't see it published, I'm not going to pay attention to it. So yes,
Great.
the first
Okay.
study was published actually about 32 years ago. And since then, the last time I looked, there were 13,027 published studies on that, on mycotoxin antibodies.
Okay. Well, we might ping you for a few of those to include in the notes. We can probably actually find a lot of these ourselves, so we may not bug you. But I did want to ask a follow-up on this, which is my understanding is these mycotoxin antibodies are IgE and IgG, but
Correct.
not IgA. So is there a reason why you're not including IgA?
Yes. IgG is the one immunoglobulin we have most of in the body. We don't have that much IgA, and 20% of the population, the general population worldwide, doesn't produce any IgA. So the best one to use is IgG and IgE. IgE is an indicator of activation of mastocytes. Now, that can lead, and what it does is, because again, this is not a biologic live substance, but just a very common, not a very strong toxin that's a molecule. This hits the mast cells and they release pro-inflammatory cytokines like interleukin 6, interleukin 17, et cetera, et cetera. Interleukin 6 is a precursor for a lot of autoimmune disorders. So and it goes hand in hand. You can then measure interleukins and et cetera, et cetera. And what that can cause is mast cell activation disease, mast cell activation syndrome, or mastocytosis. My latest study, published earlier this year, was on mast cell activation. And it was published with a group of other doctors from Washington University School of Medicine in St. Louis. So the IgG is the long-term one, the one that's been, if you're colonized, you're going to have a lot of IgG. Okay? And the more you have, it's like anything else. The more of this you have, the worse you are, which indicates more symptoms, more findings on examination, et cetera. They need treatment desperately versus they need treatment.
Okay. So it's you're looking at the level of antibodies in a quantifiable fashion. And how helpful are the lab reports for the clinicians in our audience, or I guess for the patients who might do a test and then they're wondering, I believe it's reported in sort of green, yellow, red. Is that how the lab reports?
It used to be, but it's now all red.
So any level of finding is considered positive?
It's a positive, yes.
Okay. So
There's a column
it's
all the
really
way on the
more.
left. That's a light blue column. That's anything to the right of that is a positive. Now it can be low positive or very strongly positive. Depends on that particular mycotoxin.
So with treatment, can you outline your approach on this? I from what I've gathered, there's sort of 4 steps, but I don't want to steal your thunder. So can you give us sort of the high level, how you think about sequencing treatment?
Sure. Number 1, the first rule of toxicology is get the patient away from the toxin or the toxin away from the patient. So that's the first thing I'll do. Otherwise, they're not going to get better if they continue living or working or being around, the moldy place they were in to begin with. The second is an antifungal, itraconazole. I see a lot of people being given fluconazole. Fluconazole treats single cell molds. There's two types of molds, single cell and multiple cell. Single cell molds are all your yeasts, baker's yeast, brewer's yeast, candida, etc. They don't touch penicillium, stachybotrys, etc., aspergillus. Itraconazole hits both single and multiple cell. So you use that.
And Dr. Campbell was nice enough to send over a few really compelling photos before and after. This first image here is a visibly reduced abdominal bloat after 3 months of itraconazole. The second image of psoriatic arthritis, a skin rash or autoimmunity essentially after 6 months of treatment. And then also neck rashing clearing after, again, treatment with this itraconazole.
The third is a group of targeted nutraceutical supplements and vitamins, 8 of them. And the fourth is nutrition. You want a low inflammation, low histamine diet.
Regarding Dr. Campbell's protocol, there's a number of supplements: phosphatidylserine dosed at 500 milligrams per day, melatonin at 3 milligrams per night, B complex, standard product dose, usually it's 1 capsule per day. Magnesium, again, these are his recommendations. Magnesium, 500 to 1,000 milligrams per day. Vitamin D, 5,000 IUs per day, pretty standard dose. Omega, this product called Omega Q Plus Max at 2 to 4 capsules per day. A soil-based probiotic, sound familiar, at 4 billion CFU per day. And also vitamin C at 1,000 milligrams 3 times per day. Well, I can vouch for low histamine. Yeah, for some people that is super helpful. In my observation, the low histamine diet for some people is a game changer.
We're all in the bell curve. You always see some people at one end of the here and one end over there. The great majority is right here. So those are the ones that we see. Yes, we'll have a few of this kind and a few of that kind. But the majority are right here.
So helpful to know that itraconazole is much more important than, or really the only one to use over other antifungals like fluconazole. Are there any natural anti-mold treatments that you use? I know in the Lyme community, Dr. Zhang had some really interesting research looking at various botanicals that were shown to be similar efficacy to pharmaceutical antibiotics. Anything here that you're aware of?
The great majority of the patients I see who have seen at least 15 doctors, etc., and they've tried everything. They've tried all the natural, the oregano this, the oregano that, the this, that, the other. I had even one patient using shark cartilage enemas. I mean, I've seen it all. They would not come see me if they were well. And I wouldn't get all these emails, and the majority of them say, I've been doing either this doctor or that doctor, and I won't mention names, protocol for 2 years, 3 years, 4 years. The protocol that has been published and that I use is 6 months.
Well, I just want to applaud and say how much I appreciate the fact that your entire protocol is 6 months, because this is one of the things from some of the other mold camps that I've really struggled with, which has been, well, you'll start to see results around 6 months. Most people, you'll start to see some results then, and they may require a year or a year and a half. And for our audience, you may have remembered how I sort of pushed back on one of our guests who had made that claim because, boy, I just have not seen anything clinically that takes so long to respond. Usually, like I said earlier, and my observation here, if we're on the right path, within the first month or two of treatment, the patient's clearly going to know. They may not be fully recovered, but they can at least say, yeah, I'm definitely improving. To have to wait, as some in mold care recommend, until 6 months to be able to establish if they're seeing that initial improvement, to me, that just reeks of the person's, going to have such a hard time remembering how they felt 6 months ago. The likelihood of just some sort of bias in that answer of I'm feeling better, I think, is extremely high.
Maybe I wasn't clear enough. It's 6 months total treatment. They first start feeling better within a couple of months. They first
Yeah, no,
start
I'm with you.
noticing.
Fully agreed. Yep, and that's the response curve that makes the most sense to me. But what I'm saying
And
is some of the mold experts I've interviewed have said you won't see any improvement until the 6th month. And so, by month 6, you're seeing initial improvement. And that just seems like way too long.
yes, yes. And by the way, privately, once we're off with the public, I'll be happy to share a bunch of these emails that I get every day.
No, I love it because I do think there's something here in mold care. Having had some exposure, I can at least say that when I was in a moldy environment, I felt pretty poorly, and when I got out of it, I felt a lot better. Maybe I got out minimally skeeved, but that showed me right there. There's something here. There's something to this. But yeah, I keep trying to find an approach that resonates, and I have to say, this feels like the most intuitively and just reasonable, pragmatic approach that I've seen in terms of it's not going to take forever. I mean, that's the one thing that I really struggled with. When you tell me it's going to be 6 months to assess initial response,
Okay. Yeah.
I don't think the body takes that long to improve. It violates so many biological norms.
And I'm so happy to hear that from you. And I congratulate you on thinking. Your way of thinking is very, very good. I will say
Thank you.
this. Um, I've talked to many colleagues, and I say, why don't you deal with this? Why don't you help people? Why do you just turn them away? My usual response is two. One, it's a huge insurance hassle. And second, they say, well, they usually bring me a bunch of stuff they've printed off the internet and tell me to do this. And nobody wants to be told what to do. And I have taught, and I have the credentials, and because of that, I've taught this to faculty at 6 different medical schools, including Harvard and Oxford in the UK. And when they leave, when I get off the podium and the next speaker gets up, I'm now known as Moses because the room empties out and everybody follows me out to ask me more questions.
Well, I mean, I'm with you. I like I said, I do struggle with the way I see it. There's sort of two camps. There's the Neil Nathan and the Shoemaker camp, and upon scrutiny, neither one of those has really resonated just off the bat. And I'm not saying this to denigrate anybody. I think we're all on the same team. We're all trying to help people. This is just me making an academic critique of someone's position, not the person. But the Shoemaker approach seemed to be so convoluted and so riddled with assessments and tests. Again, I have not found anything that requires $5,000 worth of lab work and pages of lab results to be able to, make the diagnosis. And then with the Neil Nathan camp, he seemed much more practical, but where he lost me was with the 6 months in many cases to see initial treatment. And then like I said, we tried his urinary mycotoxin approach for about a year and a half, and I just couldn't make any correlation. And that sort of brings me to the next point that I'm curious to hear you discuss, which is binders. Binders were essentially a fail for us, with one caveat, which in people who have bloating and loose bowels, binders can sequester bile and improve those symptoms. And sometimes I think people confuse I had less sort of bile acid diarrhea from the binders. Therefore, it's helping with a mold issue. So it is important to kind of parse those two if someone's seeing an improvement in loose bowels, bloating. But as it pertains to mold, for me, I could not tell patient after patient after patient, month over month over month of binders. And we tried low dose ramping up. We tried aggressive dosing in other cohorts. And I just could not get a signal of people improving.
There's two
And I know
studies.
you,
There's two
please.
studies on binders in humans. There's a lot of studies in sheep, goats, rats, mice, rabbits, things like that. But as far as in humans, there's two studies, and they go through the whole thing. These are public studies that have to be pretty thorough. One is very brief. One is a study, but it only concludes they don't work. I don't like that. I want to know why. Okay, don't say it doesn't work. say, why doesn't it work? Give me a little more information. The second one was more complete and went through all the different types of binders and all the different mycotoxins. Well, what they said, it does help remove one mycotoxin, which is aflatoxin, but aflatoxin is not found indoors, and that's been published. However, and it does not, and they concluded that they tried against all the other mycotoxins and it did not work. Plus, it had a tendency to bind nutrients and micro and macro nutrients, zinc, magnesium, things that we really need, because our ancestors, when they went and they pulled out well water from the earth, it was full of minerals. We now drink purified everything
Right.
with nothing in it.
And our food supply is becoming increasingly compromised, and there's a loss of things like organ meats and other vitamin-rich, especially certain B vitamins in the diet. Yeah, and it's actually a growing concern that I have is the various B vitamin insufficiencies. B12, sure, we've all heard about that, maybe folate, but there's some literature, and this is probably because we see a decent subset of people with fungal overgrowth. And at least according to Mona Morstein, she's a naturopathic GI, fungal overgrowth is metabolized similar to alcohol, so it's going to deplete reserves of thiamine, B1, riboflavin, B2, and also copper. And we've been experimenting with some of these doses or some of these vitamins in higher dosages, and it seems to really bring some people back to life. There's a few studies on post-exertional malaise or fatigue from exercise, and thiamine in a high dose being very helpful. And we've had a few people report back who, I mean, clearly it was better. I had one lady say every time she's on thiamine, she feels normal. Every time she comes off thiamine, she feels tired. So regarding vitamins, binding them and depleting them, it's something I've become even more cautious of late.
I agree. It's very important to have those in you because, first of all, like vitamin C or magnesium, if you don't have enough levels of magnesium, you can't absorb vitamin C. And then there's 6 types of magnesium. Which do you want to choose? Some are more bioavailable than others, et cetera, et cetera. So, there is a lot of that is very important for every human being's metabolism.
Yeah, no, fully agree. As we come up a little bit here proximal to the close, I did want to circle back to a concept that we had earlier. You call it, I think, the sensitive patient. I think of it like the chronic patient in terms of the person who's just not responding. And again, I have a soft spot in my heart for these people because in the clinic, they come in and they've really just been dragged through the mud in terms of financially. They've spent a ton of money. They've been told, look at my 20 labs, like I said earlier. And each one of those labs has 1 or 2 or 3 diagnoses. So now they come in with a list of, what are your medications? What are your diagnoses? And the diagnoses sometimes is 25. And I'm saying 25 items. I'm saying, oh my goodness, this poor person. So now their self-view is I'm really sick. I'm a chronic case. And we know that that's not good for anyone's limbic system. And that's a really important part of environmental tolerance and reactivity and stress and sleep. So what I really appreciated about your perspective on this was if someone's not improving, whether it be Lyme, whether it be mold, within a few months or so, we're not on the right track. And it shouldn't be like the Lyme case you mentioned earlier. And we've seen some of these in the clinic now that we're really doing more with Lyme directly. They will be treated for 2 years. And when we probe into, well, maybe there's something here we can learn from that treatment history. Did you feel better at any point along the way? No, doc. 2 years, I felt no differently. That is just egregious in my mind. I mean, if you're not getting someone results by 6 months, I think it's time to refer them somewhere else, or at least vastly change the line of, if you're a doctor who's treating Lyme plus other things, go to one of the other entities that you work with.
Yes, I've seen a number of these people who come in and they're sensitive to everything. I mean, you can't give them any type of supplement, much less medication, that they don't react to. And their foods are limited, et cetera, what they consume, so on and so forth. What I have noticed is that many of them were on so many supplements at one time.
Mm.
20 to 40 supplements a day. Well, I started researching this. Why would a supplement do this? Supplements are made in the United States, Netherlands, Switzerland, but a lot of them are made in China. And every so often there's a recall or a warning from the FDA because they found that it was contaminated because they weren't so careful over there as we would like them to be. And when you're taking that many, and some supplements are more natural than others, some carry more fillers and things like that, so on and so forth. When you put that into the body and the body just says, quit, I quit, don't put anything down here anymore. I have to clean myself out. I want to do this. The only thing that I found helpful is if they do infrared sauna every day for about a month and just get it out through their pores because they're no longer able to get it out the usual way because they can't take anything. And this is not something you eat or drink or swallow. So I've used that to a certain degree, and it's been helpful in those very, very sensitive. And then you start back baby steps by baby steps,
So
baby
it's a
steps.
pairing of a supplement holiday, so to speak, along with the infrared sauna.
I first start out with supplements. For example, there's some really surprisingly good studies on curcumin,
I'm a fan.
and I'm a fan too. I take curcumin every day. So, and they're now talking about curcumin for longevity in very strong, serious studies, where there's 10 authors from all these universities all over the planet. So I think you start low and go slow, little by little, little by little, and you help them back up because I'm with you on how you feel for those people.
Do you find that the sensitivity has another layer to it beyond oversupplementation and maybe a little bit of sort of supplement induced toxicity, if you will? I'm assuming you're also seeing the sensitivity being driven by mold and sort of the chronic immune stimulation that this leads to.
Well, that's a very good question because sometimes I've wondered if there was a way to measure non-mold, non any of that stuff, but from these things they took, who knows where they were made. They have nice names. The bottle has a nice name on it, but like a study that was published a year ago, November, 11 months ago, they took 60 of the most common supplements to the lab and they measured what was in the bottle versus what's on the label. 11% had in the bottle what's on the label. 40% had nothing in the bottle that was on the label. And these poor folks, they go to the internet, they find, oh, this is going to help you do this, do that, do the other. You don't really know what's in there and if it's really a good. So that's why people like you and I guide where, no, don't take this one, take this one.
Yep, per se. And also why, the cheapest supplement is not usually the best. The other side of that coin is there are supplements that are just way marked up and you have people who are ripping people off with good marketing. So I think the truth lies somewhere in the middle. And oftentimes I like the healthcare provider, only supplement lines, and some of them they're kind of healthcare provider only, meaning they sell online and they also sell to the doctors. But if you have the doctor as your customer, they're going to be asking better questions. And so that's one assurance. And usually those supplement lines, they're going to be like 70% on a scale of 0 being cheapest, 100 being the most expensive. They're going to be a little bit more on the expensive side, but that's usually because they're formulated to be hypoallergenic and they're going to do things like assays for heavy metals and have a little bit higher standards, again, because their customer base is the most educated. It's not a fail safe, but I think it's a good principle to use.
I agree. That is a very good one. I agree with you.
Other supplements that you're a fan of, I know you had mentioned vitamin C, and I've seen you discuss a few others like melatonin, B complex, vitamin D. Is there a short list that you think people may want to consider?
Um, you know what? again, I read before, okay, here's vitamin D. You should take this. Why? What does it do exactly? What is the mechanism of action? For instance, it does wonderful things in the brain. Prevents you from developing Lewy bodies. Well, I want something like that for my brain. So why wouldn't I give it to a patient? The issues with magnesium, over 350 enzymatic changes in the human body rely on an appropriate level of magnesium. Oh, and by the way, going back to vitamin D, if in my practice, everyone gets at the beginning a level of vitamin D. I'd say 85% of patients are around 30, 32. And the best levels are between 50 and 80. So all these things are, and again, I've published an article on magnesium. So it's something that I researched because 35 years ago, how much was there on any of this?
I think we're in much better shape now than we were 20, 30 years ago.
Much.
This conversation has been fantastic. I would like to do a follow-up because you've done some work on distinguishing Lyme from mold, and I think this is a crucially important distinction to make because the symptom overlap is so intensive. I mean, they're very, very similar in terms of the heavy neurological involvement,
Yep.
paresthesias, muscle twitching, things like this. So I'll follow up with you online or once we're offline, and maybe we can get that set up because I think, especially knowing that some of the Lyme doctors will do 2 years of treatment before reappraising the efficacy of their care. And again, I think doing it with good intention, all right, we're all on the same team, but I think our standards need to progressively get better and better every few years or so. So if we can help someone upstream at that fork in the road make the right pivot, whether it's a doctor or if it's a patient, I think that would be huge. So more to follow. Hopefully we'll set that conversation up. But what would you want to offer people in close? Is there any words of wisdom? Is there a website or anywhere else if they wanted to hear more from you?
If you have antibodies to mycotoxins in your body, it's going to cause a cross-reactivity with other tests, including testing for Lyme, EBV, CMV, HHSV6, all the viruses. So they're going to light up, but you don't have those. It's just the cross-reactivity. And once you get treated and your mold antibodies go down to nothing, although you retest for that, they won't be there because it's just a cross reaction. You don't have those.
That's a great insight. I mean, this is one of the things that's always been the criticism of antibody testing. It's indirect. It's diagnosing via smoke, not via fire. And there's a time and a place for antibodies, I think, but they should really be used with some caution and some circumspection due to that. So yeah, can't wait to have that conversation. Where would you point people? Is there a book or a website? I know you have 100 or so articles in PubMed, which is amazing. But where else can they hear more from you?
Well, I have my website, andrewcampbellmd.com, and they can download studies. They can download all kinds of webinars, videos, etc. And in my Myco lab, if they go to the YouTube channel, they've got 60, 70 of my videos on everything. Breast implants, Lyme, children, older adults, etc. One last thing I want to mention, mycotoxins, a study from Rutgers University in New Jersey School of Medicine showed that mycotoxins can cause up to 70% of MS, multiple sclerosis. Knowing that, I've treated so many patients with MS who come to me in a wheelchair or are not able to walk, etc. And a year later, they're playing volleyball or whatever the heck they want to do.
Wow.
And you could do this tomorrow morning.
Wow. I mean, this is phenomenal to know. And another area where there's overlap with Lyme, because this is something I haven't seen any of these cases firsthand myself yet, but I am a member of ILADS, and there's been a number of clinicians who've remarked pretty phenomenal results with some neurodegenerative conditions, including but not limited to MS. So there's options out there for people with MS, and I didn't realize that mold could be, I mean, I guess it makes sense in terms of the affinity that mold has for neurological tissue.
I agree.
Well, Andrew, I'm glad you're out there doing what you're doing.
Thank you.
Thank you for taking the time.
Thank you for your kindness. Thank you very much.
And hopefully we'll talk soon.